Hello, everyone. Welcome. My name is Manmeet Magoo. I am your host today for the Mobility Mindset podcast. In this podcast, we're bringing together families, medical experts, and advocates to discuss the realities of raising kids with special needs. And today we have a really, really special guest. We have Dr. Elizabeth Condliffe. Hello.
Hello.
Thank you for being on the podcast. We're super excited to have you.
Great to be here.
Awesome. You have a pretty illustrious career. You have a really diverse background, and you've also been kind of at the pinnacle of research in robotic rehabilitation for children with cerebral palsy, including devices like the Trexo device. So I figured maybe we can start off the journey there on how you first connected with the Trexo, first device, first study. Maybe you can walk us through that a little bit.
Yeah, sure. So first exposure, actually, I was very skeptical. Somehow it was presented to me as a device to help children who could walk better. And I didn't see the potential there. But shortly thereafter, a family in Calgary where I work was buying a Trexo, was open to collaborating. And they had really reasonable goals for why they wanted to use the Trexo. They wanted to see if it brought their daughter some joy. And to see if we could collaborate and see if I could measure any other changes. And so that was the first project, was a case study right when this participant received her Trexo and following her in the home and the school and what changed over the first 3 months. And that study was really quite inspiring. We'd done some work knowing about impacts of robot-assisted walking in other populations and other types of robot-assisted walkers and sort of thought we wanted to measure some things related to motor function, spasticity, and bowel function. And we noticed clear improvements in head control, which the family noticed was meaningful to them. They had to support her head less when they were doing the transfers. And when she was up in her wheelchair, she was turning her head more voluntarily to interact. She started to have bowel movements more easily and more frequently. And we got some early indicators using a clinical measurement of spasticity that may be improving in her knee flexors. And anecdotally, we didn't even think to measure sleep. And anecdotally, they told us her sleep got better. And so now we measure sleep and we've been able to replicate that. That was not just for her. That happens for many children who have trouble sleeping.
So I guess, yeah, was there an aha moment in that initial case study that was like, wait a second, there's something more to this than just gait and walking for you?
Yeah, I mean, we set that study up to look for more than gait and walking. I think one of the aha moments was realizing that you guys were aware of that. I was quite skeptical, having worked with some other devices where people were going to cure inability to walk or
Fix walking, essentially.
Yeah. And really, especially with a device like Trexo, it facilitates walking and it can improve, we've now shown, motor function, including things like walking. And that can be important, but some of the more important things are the sort of wraparound effects in many areas of life.
Yeah. And then I think after that, it's been basically a lot of research. Maybe we can talk about some of the other studies. Like one really unique one that comes to my mind is I think the 70 patient prospective review that you did. Maybe we can talk about that.
Sure. So we made the mistake in nicknaming that one Trexo Home because you also have a product called the Trexo Home, which can get confusing. But it is for people who have purchased or leased a Trexo Home and have it in their own home environment. They may be using it at school or wherever, but we wanted to get patient-reported outcomes, which in this case is often parent-reported outcomes. But really, if we use objective questionnaires or as objective as questionnaires can be, what outcomes are people noticing? And I think you said 70 participants because that's the paper we've published. We've now analyzed a cohort of over 150 and the results. So when you have that and we evaluated people before they got their device at 1 month, 3 months, and 6 months. And of course, these are really busy families who are juggling lots and they didn't send us data every time we asked. So we got a statistician involved to help us see through it. And so we run statistical models. But essentially that has helped us see that there are statistically significant improvements in motor function. Although if you average it out across the population, the average improvement is so small you wouldn't necessarily see it for one child. But there's enough children having an improvement that is measurable that it's statistically significant. And we're also getting improvements in physical activity, so sleep that we now measure consistently. And over time, children are walking faster. And all of those that I just mentioned improve in both unadjusted models. So if we just check what happens over time, but also when we control, so adjusted models, when we control for how much they're using it, how young were they when they first got it, what was their baseline level of function, and all of these other things. So those changes are really robust. And then there's some other changes that people are noticing that are mitigated by some of the factors. And that's for when the paper comes out. But essentially, it's proving to be a really interesting result. It's very hard in the rehab space to get 170 participants in a study.
Yeah, I was just going to talk about that. Like recruiting is so difficult, and then actual adherence is so difficult because yeah, you're not going to, especially some of these studies that are designed in a clinical setting, you have to drive to the clinical site to do this regularly, and then life gets in the way. And this is kind of majority pediatric studies have been plagued by this issue where they struggle to get, that's where you see pilot studies, five patients, 3 for 10.
I don't think that's just an issue with pediatric studies. I think that's an issue with a lot of pediatric rehab delivery. When you need to come to a rehab center, and specialized pediatric rehab centers aren't on every corner, they're not even in every city, it really limits how often you can come and who can come. And so, we have a study running here at our rehab center as well for those who can come. And we're using the Trexo for slightly different reasons in that study. But the one I was just talking that we nicknamed Trexo Home, it's people who get it and who use it, and we don't prescribe how much they use it. So that was another interesting thing we saw, that while the number of times they use it per week went down over the course of 6 months, just a little bit, the actual number of minutes they used it for and steps that were taken didn't necessarily go down. So people are walking faster in less time, essentially, at the end of 6 months, but they're still getting the same dose in terms of steps of intervention and benefit from the assisted device.
So 150 total patients, is that pretty much already the largest study for robotic rehab in pediatrics?
I would expect so. It's the largest
Wow.
one I know about. As a scientist, you never want to say first or
Yeah.
only or ever, but there was a very large one done in Switzerland where they did a retrospective review of all the participants who had used a Locomat, and I can't remember how many
Okay.
people total they had in that one, but certainly for prospectively collected data where you plan to do a study, yeah, it's the largest one that I'm pretty confident.
So this is probably something worth mentioning, that whoever gets a Trexo device can potentially participate and be involved in this research with Dr. Condliffe. And you can consent to this, and then your data can then be shared with Dr. Condliffe, and it can be aggregated to essentially move the research forward, move innovation forward, and then on a broader level, use some of these findings to make a stronger case for Trexo, for reimbursement down the road. And I think there's another unique aspect that you added to this, which was potentially I don't know if that's still there, but at some point sharing a result with the participant as well that they can use. You want to talk about that?
Yeah. We are happy to make an individual report. And in fact, the first, I think, 50 or so, we did it for everyone. And then I think we sort of got the feedback that it wasn't that important to many families, and it took quite a bit of time to create. So now we do it by request. But we're more than happy to use an individual report of what we observe, steps you taken, what data we received. In all of our studies, we try very hard not just to save the knowledge sharing for the end when all the results are done, but if we can share some results with each individual, we try to do that.
I think that is insanely valuable, and every person should use it, because you have an entire research team, a statistician who can then basically produce some sort of a quantified results that you can then use it to apply for insurance coverage, or you have some objective results here that.
But Manmeet, you and I are geeks who like numbers, and so we like these reports. I think they're valuable too, but I realize, and that's been one of the other big learning processes. The more and more we work with Trexo and other innovative devices, is everyone's unique, and people will use the device for their unique reasons, and they will want different goals out of the research. So that's actually something in a lot of the research we run here in Calgary that we incorporate, is that we often, our main outcome is a goal that we create in conversation with the family, rather than prescribing, this device is being used for specifically improving bowel function. We ask,
Mhm.
what is your reason for you using the device? And then we pair it with some research techniques of how we can actually combine that from different people.
Which I guess partly brings us to the Robotics study,
Mm-hmm.
where a big focus is the goal attainment score. Like, what goals do you set
Yeah.
and how do you measure any improvements? Can you talk about any potential good findings that you've seen, good or
Sure.
bad, whatever findings?
Yeah. I'll talk about both. Our main outcome was a way of measuring goals, the Canadian Occupational Performance Measure. And we had not only statistically significant improvements, but every single participant in that study had improvements. And almost everyone improved to such a large effect that it would meet sort of a threshold that's been defined as clinically significant. So to summarize that in less geeky speak, everyone improved.
What type of goals are these?
So everyone's score is sort of a summary of the 3 to 5 goals they set. Most of the participants had a goal that was related to gait, mobility, head control, transfers. So almost everyone had a goal that was gross motor function. More than half the group had a goal that was related to activities of daily living. So wanting to be easier to transfer to get into the bathroom, or wanting to be easier to feed. This was someone who couldn't use their upper extremities to feed themselves and was fed by someone else, but had troubles with head control and staying engaged. And so wanting to have the head control and the eye contact improve to signal when they wanted to eat.
Are you able to share the story of a particular child anecdotally or without
Yeah.
names or
I'm afraid I didn't prepare to have one child's
sure?
all 5 goals sort
Yeah,
of
or any of
combined,
these that
but
come to mind for you, yeah,
yeah.
that were
Yeah.
like pretty inspiring to hear about.
Yeah, I think that goal of being able to engage more and participate more in indicating when you want to eat is a pretty good one. Certainly, there were participants who wanted transfers to be easier. And this seems trivial to say the word transfers. I'm talking about, getting from a wheelchair to a bed or wheelchair to a toilet. But particularly for many of these children who are getting older and growing, while it's really easy to lift your baby to carry them around. And then we start lifting less and less as children grow. Many children who have significant mobilities impairments continue to need to be lifted or need to be sort of pulled into standing and take a few steps. We had one participant where the family just really noticed they were having to put a lot less of their own back, literally, into it. And we've had quite a few families where the parents have troubles with their backs and back pain. The
Because
carry
the
down
kids,
effects.
is it because the kid is gaining more core strength?
So we can't say exactly what happened. We didn't measure core strength. It could be a reduction in spasticity. It could be an increase in strength. It could be an increase in the control of balance. We did do a measure that looks at if balance is improving, and it is. We have that measured objectively. So I think it's probably a combination. We tried to measure strength objectively. It was really challenging. In everyone, we were able to measure it objectively, which was really less than half. It did improve as well. So it's not just mobility, it's the multifaceted being able to move more and having this exercise level facilitated is leading to, I sort of separated it out as a rehab benefit, a benefit that is lasting beyond when you're using the Trexo, whereas there's assisted device benefits that you're getting every time you use the Trexo, but you need the device available to use it.
Wow. Yeah, I mean, you put it so well. Like, it's not just about effect be happening on the legs. It's not just about walking. It is so much more, and all these ripple effects that just start to happen. More energy, more endurance, more balance. That's pretty incredible.
Yeah, and we're still talking largely physical things. We
Yeah.
asked about impacts on the family and, being able to do things as a family that you weren't doing before. Many families actually commented it was really meaningful that they were able to go for a walk and hold their child's hand, and that they can't do in other ways for many of the families in this study. And so, we did some qualitative research, which is essentially interviews, conversations, and then you have some structured techniques that lump it into themes, and some of the themes are positive and some are negative. But the impacts on the family overall were really largely positive impacts. Where we saw some of the negatives are sort of around logistics. And we know with anything new, logistics have to get figured out. Any new sort of assisted device is really resource intensive. And you need an adult with you to set up and help the child get in the device, as they often need in many, if not all, aspects of their life. And then this is a device that if you want to use it everywhere you go, you somehow have to get it everywhere you go. And so these are the things we need to figure out, is really who's getting these really big benefits that we're finding, and make sure our research criteria aren't so strict that we don't see the breadth of it. And then how do we solve these logistics to make sure they get all the benefits that are there?
Yeah, like measuring something like quality of life improvements is so difficult.
Yeah, very difficult.
Probably a science in itself. And there's some probably validated questionnaire outcomes like the promise and
Hmm.
others. But what are some limitations that you see with these? And
Hmm.
yeah, where do you see the road ahead for this? Is there ways to better measure this?
Yes. Yeah. So quality of life is a construct that's very individual, and yet you're right. It is a science, and people focus on ways of measuring quality of life and also the implications of that. So certain quality of life measures will measure quality of life, and is it health related quality of life or other aspects of quality of life, or quality of life as a whole construct. And then some of them will also ask it in specific ways that you can convert that to what are called QALYs, quality adjusted life years, which helps health economists look at what are the trade-offs of using this in terms of financial means, taking it from quality of life. So you want to use one of those measures. Ideally, those are the really good ones. But a lot of those ones are set up for a general population, and they have a lot of biases in them that many of our, we saw a couple, and then our families will tell us more. There's an assumption that if you don't walk for all activity, that your quality of life is inherently lower, which essentially there's an assumption that if you have a disability, your quality of life is inherently low. And there are things that make maintaining a high quality of life more challenging. But many people with disabilities say, it's a different ability, not necessarily something that we should see negatively.
Disability.
Yeah. So the bias in the language of how a lot of these questions are asked and scored is tricky. There are some good ones for people with disabilities, but they tend to be very population specific. So there's one specifically for children with cerebral palsy, and it's got an adapted version that is specific to teens with cerebral palsy. But what about the adults, including small adults who could use a Trexo potentially? And then there's other specific ones for people who've had a stroke or other, low back pain, other causes of disability. Yet in research, you often want to use one measure that includes everybody.
Yeah. I guess talking about inclusion,
Mm-hmm.
that's also been a core component of how you want to conduct research, is like, how do we have inclusive mobility? So, you're doing the study probably the only for GMFCS5 or that level of severity, or that level of impairment, whereas a lot of the traditional ones have been focused on kids who can, as you've already mentioned, like kids who can already walk, and
Mm-hmm.
focused on changing the gait. And I think as part of the Pony Lab too, you have a broader goal, where you've been very careful to not limit it to just CP, for example. Do you want to talk about that?
Yeah, sure. I think there's a growing movement in science, and certainly what we're trying to do in our lab is to make sure that our science can generalize to help people make decisions. And certainly there is a role for very specific restrictive inclusion criteria to figure certain things out. But when we're studying impacts on a real world use or on a general population, we want to know whether it would have carryover to real world. And we were hearing very early on in some of our engagement with Trexo users, through our experience in that Trexo home study and through people who wanted to use one here in Calgary, that often the families who are most interested are those with the most motor impairments. So you alluded to the GMFCS, the gross motor function classification system. So 5 is the group with the most motor impairments. And so we wanted to include them in our study. And we were also hearing from a lot of families who were excluded from a lot of other research because it was specific to cerebral palsy, and their child may be known not to have cerebral palsy, or there may be debate whether their child's diagnosis is classified as cerebral palsy. And cerebral palsy isn't one condition, it's a group of disorders as it is. And so in this case, I thought it was more important, rather than limiting it to people who had a specific diagnosis, to limit it with people who had a specific impairment. In this case, mobility impairment, to the point that they didn't walk independently or didn't walk in the community. And so we decided that would help us select the population of people most likely to benefit. And we were partly able to do that because we focused on goals. And so the reason for use could be very different, especially for someone who has very limited voluntary movement of any kind. You get a different set of goals often than someone who may walk in some settings with a walker but uses a wheelchair most of the time, is able to use their arms quite functionally for lots of activities of daily living. They're using the Trexo for a different reason. So we were able to be more inclusive by setting what we were measuring as something that could adapt. And I'm very hopeful that that'll better help inform families and clinicians who are trying to make choices.
Let's maybe switch gears to your background and how it might have helped some of these. It's a very, very unique background, and probably from aerospace to pediatrics, it's as interdisciplinary as it's inspiring. Let me briefly mention it.
Mm-hmm.
First, you did mechanical and aerospace engineering at Princeton University. Then you switched to a master's in biomedical engineering at Boston University. Then that wasn't enough, so you decided to pursue an MD at U of T. So you became a doctor, and then you did a specialization in PM&R, and then you decided to do a PhD in biomedical engineering. Firstly, you must really love studying.
Yeah. Yeah. I mean, it's truly to be able to dedicate that much time to studying and learning something, that's a really privileged position to be in. And I like learning new things and figuring out new problems and thinking about what that's going to let me do, for sure.
What drove you to shift from, I guess, trying to engineer aeroplanes to engineering better outcomes for kids?
Yeah, so I was most interested in studying the human body in outer space. So that's what put me
Interesting.
in mechanical and aerospace engineering. And so I always had an interest in the human body, and how the human body moved and responded to challenges. And I got introduced to neuroscience in my final year of my undergrad, and that really was a big part of inspiring the shift from the challenge of outer space to the challenge of physical disability or different abilities. And so that was the shift. And then I decided to pursue studies of human movement more in this space, and just really met a physiotherapist, scientist who was my master's supervisor, who really opened me up to the world of rehab and all the potential, and encouraged me to pursue physiatry, where we learn not just about physical impairments, but also the multi-system impairments. And I think that has been really helpful for finally getting it through my thick head, the benefits of and impacts of potential device like a Trexo.
So yeah, maybe we can dive into like how did that engineering plus medicine really help you in better research decision making? Anything that specific comes to your mind?
Yeah, I mean, some of it is the Trexo wasn't the first robotic walking aid I'd heard of, and some of that had to do with being in a biomedical engineering program and maybe having a little bit of a geek mindset and being interested. So when this family approached me about potentially studying a Trexo, I already had a bit of a basis of things I'd be interested in and knew where to look for some literature about what would inform other things we want to measure. Yeah, I guessed a few things right. It was smart that we measured head control, and it was smart that we measured bowel function, but it wasn't perfect. I completely missed measuring sleep. So I think having the engineering and the clinical background enabled that. I think it also has helped with conversations with Trexo and with other industry partners. Every now and then I end up on a call with an engineer, and I probably sound too clinical or maybe too engineering if I'm on the call with someone else, but I am more likely to understand the vernacular. And also I've had enough experiences where I meet a really brilliant engineer who uses all the wrong terms clinically, such that it's so easy to think they don't know what they're talking about. But because I've been living in these two worlds, I've been exposed to that enough to hopefully try and help translate and make sure that we get to a common conversation, even though we might both be speaking English.
No, I mean I've seen it personally where you'll be having clinical hours with patients on one end and then come back and you're giving us ideas on how we should redesign the product maybe a little bit better or how we can improve things. So I'm sure it absolutely helps, and we definitely see it as well. So I guess it's kind of made you a bit of a thought leader in this space. Moving ahead, what's the future direction that you see yourself going in? Any Any are you planning any bigger, longer trials?
Yeah, we need to get funding always, but I think there's still a lot more to be done. We've done, yes, a trial that included 170 participants, but it wasn't a well-controlled trial, and it wasn't one with a lot of objective measures that, can't be biased by natural human nature. And a few people have done small controlled trials, and so we need to combine all that literature that's coming out. And fortunately, it's a really collaborative group of scientists that have been working together so far. So we are chatting and working to how do we combine this? What do we see we should do next? And I think some of the problems we need to work on is from that qualitative work, the logistics piece. Are there ways that we can make it easier for children to access Trexos that is equitable for everybody? Especially if we start thinking about moving beyond research and we want people to be able to access the device without any financial barriers, but also without any barriers related to their parents' time. So I think we need to solve some of those issues. We've also noticed some really promising effects specifically related to spasticity. And I think we need to compare how robotic walking does versus other treatments for spasticity, because that's something we do spend a lot of money and time and energy managing in pediatric
Could
rehabilitation.
we talk about that a bit more? What if some initial things you've seen?
So, as I mentioned in that first case study, we used a clinical measure and saw that spasticity was improving in the knee flexors. So, it's one group of muscle. And in our conversations with that family, we weren't sure if we could really connect that dot to having a huge functional impact. But we've continued to measure spasticity and started to measure it in a way that is more objective than a typical clinical assessment. And it's also more reliable. The clinical assessment, you get quite a range, even if the same person measures spasticity on the same person 2 days later. You don't always get the same number. And so our objective assessment is better at getting close to the same number, which makes it easier to detect when there's a meaningful change. And so we are seeing pretty consistent, again, really uncommon in my research experience and in the literature. Everyone who we could measure before and after a pretty intensive bout of robotic walking had improvements in their spasticity in their knee flexors. And for some of those, that also they could qualitatively tell us how that translated to when they stand, they're standing taller, or actually they can take more steps voluntarily in a row, or they need less help starting to step. And so it's having a meaningful full impact. So I think we need to pursue that further as well.
That is incredible. And very, very exciting, obviously. So maybe another thing worth mentioning is probably partly already touched on this, but on how you see the field of pediatric rehab evolving, looking ahead, like maybe I think some of the things you already mentioned were like being more inclusive with mobility. One thing I'd like to highlight is I think you've had a very high family-centered innovation, like focused on the family, whether it's what I've noticed from very beginning design, you have families involved in giving feedback and all the way throughout. Yeah, where do you see this field evolving into?
I think all of healthcare is recognizing we have not paid enough attention to patient and family voices and research specifically. So we are working on that. We don't always get it right, but we're working to engage more and figure out more meaningful steps. We need to do more of that. I've given you where I think the research agenda should go. And some of that is absolutely informed with families, but we need to do more and make sure that we're driving things where we think families want them to go too. And the other piece is engagement with clinicians. So, I wear a couple hats and I am a clinician, but I'm just one clinical opinion. And because I do research, I don't see as high volume as other clinicians. So really working to engage with the clinicians, let them know what we're seeing, but also make sure that we're responding to what they're seeing and where they see the challenges are. So that's one thing we need to do better in pediatric rehab is engage with multiple groups. I hope that addresses what you were asking.
Yeah, no, it does. All right. I think one question is, as parents that are trying to make a decision, whether for a Trexo or any equipment, what do you see as your role as their doctor? How do you see that role?
I think I am part of a team that are information providers. So as their doctor, I am part of a team that often involves physiotherapists, occupational therapists, and it's our role to try and provide information about what we think are the concern for a particular child that could have the biggest impact if we worked on addressing them, and what are feasible ways to address those. I also think it's important that families should have access to someone who knows a little bit about safety of anything they're concerned with. So it's very tricky as a clinician to stay up to date with all the potential options. And so, at our center, we've sort of delegated that I will provide information about robotic walking aids so that my colleagues don't have to be up to date on all the pros and cons of the different devices and who's safe. And that's, you and I have had many conversations of, hey, this child with this very unique profile just approached us. What's your experience? Because you guys have had the most experience with Trexos. So have you ever seen anyone with that impairment? And then I often will call my colleagues if it's unique. Hey, can you think of any concerns I haven't thought about? Because we don't want to be a barrier to accessing things that might help a child, but we don't also want to say, oh, do anything. There's no risks if there are potential risks. And I see that across my research programs, not just with robotic walking aids. One of the biggest barriers in my research has been a program where we do power training. So like think of going to the gym and really pumping iron hard. And we partner with fitness centers that are already trying to be leaders in the space of adapted fitness. And many of the trainers there really need a lot of support to show that we can encourage these children to do more than they expected, and we don't have to throttle it back. And so, yeah, I think my role is trying to help share information so that we get the right level of challenge, and in this case, device, to the right children.
Yeah, it's a very important point, I think. And I think I heard you say this previously as well, where like, yeah, your goal is the information provider to help the parent make better decision, to help the parent adjust their own pros and cons for their life to make a better decision, which I think is how it should be. But I've also seen the other, where clinician trying to make the decision, trying to weigh pros and cons on a uniform level for every family. So I think really appreciate that as well. Awesome. I think anything you would like to say in closing?
No, this is my first podcast. Hopefully it was too clear and I didn't let my tendency for geek speak to go too far.
Not at all. Thank you so much, Dr. Condliffe, for joining us on the Mobility Mindset podcast. Take care.
Thanks.